So good afternoon and welcome to this session today. It's called Patients and Their Caregivers, Challenges of Chronic Conditions on Mental Health. This is going to be actually that's our second speaker. Our first speaker has a topic, hemophilia distribution in Guyana, recorded as Georgetown Public Health Hospital Corporation from 2017 to 2022. I'm Dr. Thelma Melans, and I'll be moderating this session. And it's my pleasure this afternoon to introduce our first speaker. It's Dr. Kamela Bemaul-Sukhu, and she is an adjunct assistant professor in internal medicine at the University of Guyana in Georgetown, Guyana. And she's worked for almost 14 years in the internal medicine department before pursuing a fellowship in hematology, making her the first hematologist fellow in Guyana. And in this role at the Guyana hospital, she has worked to improve hematological care for patients, including successfully completing the first hematological surgery within Guyana. In addition to her clinical experience. So I'm going to turn the floor over right now. So thanks for everyone for being here, and please let me know if you're having trouble hearing or any other technical issues. Thank you.
And one more. Yeah, okay, great. All right, thank you. Sorry, we were just having some technical difficulties with the slide. So my first slide, you'll see a picture of what looks like a blood drop on the Bank of Guyana. So this was indeed big for us in Guyana for the hemophilia population. This happened last year on World Hemophilia Day, where Bank of Guyana lighted up with a big blood drop to support the hemophilia population in Guyana. This is huge for us. So I'm Dr. Kamela Bemaul-Sukhu. I'm a hematology fellow and specialist in internal medicine and infectious diseases. Next one. So according to the U.S. Centers for Disease Control and Prevention, hemophilia occurs in approximately 1 in 5,000 live male births. It affects all ethnic groups equally. It's an X-linked recessive disorder, and so what that means is that it mainly affects male patients. However, females will be carriers. Most of the times, the male patients will be the persons that has clinical manifestations. However, the female carriers can also have mild symptoms. According to CDC, only 8% of females have moderate to severe disease compared to 70% of male. Hemophilia A and B are the most common types of hemophilia. And hemophilia it's a disorder where there is a deficiency of a factor. So hemophilia A, there is a deficiency of factor 8, and hemophilia B, a deficiency of factor 9. Hemophilia A is 4 times as common as hemophilia B, and patients in the hemophilia A group, more than 50% of these patients will have a severe form of the disorder. Right? So the clinical severity or how the patient manifests their symptoms will depend on the factor level that's deficient. So for patients who have severe disease, they have just less than 1% of factor level on board, right? And this accounts for 60% of the cases. Patients in the moderate group have 1 to 5% of factor on board, and this accounts for 15% of the cases. And the mild cases, they have more than 5% or less than 40% of factor. And this accounts for 25% of the cases. Now, based on their severity or how deficient the factor level is, this is how they will manifest clinically. So for the severe patients, they usually have spontaneous bleeding. So these are patients that will bleed spontaneously, meaning that they probably don't even need to move. They will just be sitting and can have a bleed. So that's what we mean by spontaneous. So they have spontaneous bleedings, and it's frequent and it's recurrent into their joints and their muscles. Patients with moderate and mild hemophilia, they usually do not have spontaneous bleeding, but what they have is prolonged bleeding post-injury or surgery, or if they have a tooth extraction. You might have heard of these cases where they have a tooth extraction or some surgery and they bleed extensively, or the bleeding is uncontrolled. So these are the patients that will fall in the mild to moderate group. To note, females do not usually have the symptoms that males have, for example, bleeding into joints and muscles and so forth, but they can have heavy menses, or they can have postpartum hemorrhage, or they can have challenging bleeding around surgery time. So treatment of hemophilia is based on the replacement of the deficient factor. And so this is given a prophylactic manner. If you're severe hemophilia, you're given prophylactic factor infusion to prevent bleeds. And if you have an acute bleed, therefore we need to treat that with factor infusion at that time. Treatment in Guyana is limited. Factor VIII donations we get solely from the World Federation of Hemophilia. Guyana actually do not procure this factor for our patients, and is dependent solely on distribution donations from WFH. Complications of hemophilia can be severe, and patients can have debilitating disorders. Bleeding can be so fatal, so challenging that it can become fatal sometimes. And it's with these contemplations in mind that I opted to do an abstract on the study of hemophilia population in Guyana, so that we can have or know and have a knowledge of what our population is in order to have an effective healthcare plan for these patients. Next. Thus far, there's been absolutely no studies of hemophilia in Guyana. The World Federation of Hemophilia had stated that with Guyana's population in 2018 being 755,000, we should have at least 75 persons then, and extrapolating from then, in 2022, we should have at least 79 persons in Guyana. Next. Next. So it's with this in mind, my objective of the abstract was to evaluate the demographic profile and clinical severity of hemophilia persons recorded at Georgetown Public Hospital Corporation in the medical and hematology clinics, 2017 to 2022. Next. It was a retrospective study. It's descriptive. And we gathered data from the hemophilia database at the hospital, data regarding gender, ethnicity, age, geographical location, hemophilia type and severity, and whether or not the patient was on prophylaxis. Those data was gathered and entered into the computer and assessed. The inclusion criteria was low factor 8 or low factor 9 level. Exclusion criteria was normal factor 8 or 9 level, or low 1 milligram factor. Next. Next. So what this graph is showing, it's the hemophilia geographical distribution. And you see here that region 4 had the majority of patients, followed by regions 3 and 5. So region 4 had 80% of the patients, and followed by region 3 and 5, which had 8%, and then region 7, 4%. You'll see that in region 4, there was the distribution of mild to severe cases. In region 3, mostly moderate cases. In region 5, both severe and mild cases. In region 7, moderate cases. And I believe, so you will see, obviously the slide is showing a predominance in region 4, which is mainly in the city area. And this may be because these persons they have more access or easy accessibility to healthcare offered in region 4. So, they're able to go to healthcare facilities and be detected. Also, there is more sensitization that probably would have been done in the Georgetown area. And so that's why we may have detected more patients in region 4 as compared to the other regions of Guyana. To note, we have been doing sensitization in other areas as far as Burmese and Antarctica. Next. Okay, so this is showing hemophilia severity and ethnicity, and it's showing, so in total, we had 76% of our patients being of East Indian descent, followed by 20% mixed race and 4% Afro-Guyanese. And then in the severe cases, we had 50% each of East Indian and mixed race. In the moderate cases, we had a majority again of East Indian with a small percentage of mixed patients and the similar characteristics seen in the mild cases. So we had a total of 26 patients, and you might say this is really small, and yes, indeed, it is a small group of people. So of the 26 persons, we have 25 patients who were hemophilia A and 1 person hemophilia B. And of the 25 persons that were hemophilia A, 8% of them were females and 92% male. Next. Okay. So gender and severity of hemophilia. Here we're seeing that the mild cases accounted for the majority of the patients, and it was in the mild case that we actually had our female population. So 33% of the mild cases were female, 67 male, and 100% of the severe and moderate cases were males. Next. This slide is showing hemophilia severity according to age, and you'll see that 60% of the patients were adults, followed by 32% children and 8% teenagers. Of the adult population, the moderate cases, the severe cases were the least, followed by mild and then moderate. And if you probably recall when I introduced the topic, I said that according to WHO and WFH, the severe cases are actually the most recorded, but in our population, we saw that the severe cases were the least, right? And this may be because of hemophilia is not sensitized enough, so the patients are undetected, or it might be that these patients with severe hemophilia who would have had bleeding challenges, those bleeding challenges might have become fatal, and so we actually don't have that much severe patients, but definitely sensitization is standing out again here. Next. So this is a slide comparing according to what CDC has predicted, or the stats that they have in terms of severity, which is more common. And so in the blue, you'll see what we found in our population. And if you look at it, it's kind of the opposite, right? So according to CDC and WHO, 60% should be severe. For us, we had 24, which was the least. All right, and just going back to the same reasoning, maybe they're undetected or maybe they've already succumbed to challenging bleeding. Next. Okay, so to summarize the results, we had a total of 26 hemophilia patients recording from 2017 to 2022, and that's a 5-year period, and you see how small the population is, but yet critical. Of the 25 patients that were hemophilia A, 76% was East Indian, followed by mixed race 20% and Afro-Guyanese 4%. Majority of the patients were found in region 4. 32% were children, 50% being moderate, 37 severe, and 13 mild severity. 8% teenager with 50% moderate and 50% mild. 60% of the population were adults, with mild severity being the most at 53%. In the mild severity were the 2 females. Moderate severity followed with 27% and severe 20%. Our 1 hemophilia B patient is a male patient, middle age, of East Indian origin in region 3. And of the severe cases for hemophilia A, and these are the patients that will bleed spontaneously, they're 100% of them is on factor VIII prophylaxis. Right? So to conclude, persons living with hemophilia in Guyana is grossly under-detected, and it's evident when we compare what our numbers should be with CDC numbers. And as I mentioned before, we did have a prediction that we should have about 79 patients in Guyana with hemophilia, and to date we only have 26, which is even less than half. So definitely, next slide. Definitely, we need more sensitization. In sensitizing the public of bleeding disorders, persons who may know that they actually have bleeding challenges will come forward and get diagnosed. Also, persons who know that they have a bleeding disorder or family history of bleeding disorder will come forward to be screened. They will encourage their family members to get screened. And also, it's important to let persons know that we actually have treatment available. So if you have a bleeding disorder, you need to come and access treatment. It's important that when we sensitize people, patients will recognize maybe they had a relative who had a bleeding disorder, so maybe they might have a trait or be a carrier of a bleeding disorder, and so that will encourage them to go and have testing done. And then at the end of this all, we hope to have a specialized center for hemophilia patients where we can have a comprehensive care management team for hemophilia patients. As you may know, for example, persons who have hemophilia, they cannot go to a dentist who do not know about hemophilia, because then they'll do an extraction, the patient goes home, and then they can have fatal bleed from that. So it's needed that you have a comprehensive team of persons that are well versed or have practiced with hemophilia patients. Next. Okay. These are my references. Thank you.
Yeah, thank you. Okay, we would like to ask if there are any questions, and if you're online, if you don't mind putting your questions in the chat, and we'll read them off of the chat. So first, I'll ask if there are any questions in the audience. Yes, sir.
Is there any families where I'm asking whether they've been able to trace the familiar connection to those patients who had the symptoms.
So in Guyana, yes, we've had a few connections where we might have cousins or relations of one family being diagnosed. And what we usually do when we speak with these patients, we'll ask them about their family as well. Like, you know, do you have an uncle or a family member that you know had bleeding disorders? And that's how we end up picking up a couple more patients. Or even females who have, like, let's say, have menstrual bleeds, you ask them if they had family members like that as well.
Okay, let me check the, there's some questions in the chat. Okay. Okay, no questions. So I have just a couple questions. Let's see. So was interested in, you know, this idea of that when people go to the dentist, they need intervention in the dental office. Do you have dentists involved in your research at all? Trying to maybe identify dental practices where patients go that might be affected?
Definitely. So I do have connections with our dental school and the next dentist in Berbice, and we do have that arrangement. So if patients from us need to have dental work, we'll refer them. And so if they come up with a patient